Hi everyone, welcome to this talk by ALANNA Higgins from the University of Nottingham. I'm extremely grateful to you for taking time out and doing this today amidst your busy schedule. And Professor Higgins is going to talk about a moralization of food through US policy and the implications for healthcare practice. And we look forward to an exciting conversation as part of the Indian Sociological Society's ad hoc group 3 Food Culture and Societies monthly lecture series. So over to you, Elena.
Thank you. Thank you so much for having me. Um, Today I'm presenting on work that is based off of the work that I did for my PhD, but then did some more work with Dan Totske from West Virginia University, who works in healthcare communication. So, excuse me, the aims and scope of this presentation are to look at examinations of government discourses in the US around food and health. Um, to do so, I did what's called a legal policy archaeology to investigate communication around so-called good food. The legal policy archaeology includes data collection methods such as archival data combined with participant observation and interviews, which I'll talk about just a little bit, but can talk more in the Q&A. So the work Dan and I did shows how there's a reliance on specific ideas of health and well-being, which prioritize the distribution of funding, and how the programs are implemented. Um, So, our focus follows the rise of the so-called food as medicine discourse in the United States, which has been discussed and starting to be implemented not only in healthcare spaces, but in policy and public spheres. Though before I get into the meat of the talk, I want to make a really important note that data collection stopped in 2022. And since then, as most of us are aware, there have been significant political, policy, and society changes in the United States, particularly around the distribution of federal funding, programs and departments now being cut or attempted to being cut, um, and a rise of not only food as medicine, but this new social push called Make America Healthy Again. So that's not discussed in this work because the data collection stopped prior to that. So I wanted just to make sure everyone was aware, right? But the moralization that I talk about in this work is still happening. And the shifts of our understanding and priorities, and then the implications from policy and healthcare that come from them, have not only become further entrenched in federal policymaking and in the social imagination of health in the US, but have stretched even further into everyday practices. So this work was done in the context of the White House Conference on Hunger, Nutrition, and Health in 2022, 2023 in the United States, specifically around the discussions of food as medicine and the rise of a phrase nutrition security that policymakers and government members at the time were really talking about in terms of public health and public food access. So the programs that are a part of these conversations, but that were a focus of my work, are called produce prescription programs. These programs are formed from coalitions. The type of members change from program to program, but typically they involve funders, the growers or farmers themselves, and community organizations. They also include doctors or medical practitioners, but typically they're attached to a community organization or funder that's involved in the program. In the US, produce prescriptions happen between 12 and 20 weeks. Again, it changes depending on the specific program, but they all typically happen over the summer growing season in North America. They target identified individuals through eligibility requirements, typically around income level. So people have to be low income to qualify for these programs. But specifically, they have to have certain diagnoses from a medical practitioner or a diagnosis of being at risk of certain diseases. These programs run in two basic forms. Either it's subsidized production, so the farmers are given money and hand in produce to the programs if they're not running the programs themselves. And so it sort of looks like what we think of as a farmer's market or a community supported agricultural program. But produce prescriptions can also be done through vouchers, where the participants are given a voucher that can be redeemed sometimes at a farmer's market, but more typically at what we call a big box retailer, a large supermarket. The programs were founded on the desire to reduce healthcare costs and to reduce so-called risk behaviors in individuals. And not all, but quite a lot of programs collect health metrics from participants. This can include weight or body mass index, blood pressure, different lipid panels, and HbA1c or glycated hemoglobin, which is a specific blood sugar measurement. So this is a diagram of a typical program. Again, they're very varied in the United States. Some programs are incredibly medical based, while others are more food justice based, and they're more concerned about people just being able to access food. While the more medical based ones collect quite a lot of data, they're very strict about who can participate. But typically, there's some sort of eligibility screening to figure out who will benefit from the program. If it's healthcare based, the healthcare provider, a doctor, a nurse practitioner will refer the person to the program. So they either get the financial incentive or that voucher to go to the store, or they get the so-called prescription, which is a box of fresh produce, right? So they receive that at the site. Not every program has this, but quite a lot of them also focus on nutrition or culinary education. So there will be demonstrations of recipes or cooking techniques, and data is collected, whether it's just how many people showed up and took a box, all the way down to, right, those very specific biometrics from individuals. And programs can have this data collection and evaluated done in-house, right? So the program itself is responsible for it, or they can use third parties to do this evaluation. And we've been seeing a rise of this third-party evaluation because these programs have started to become funded from federal money in the US. This work is based on a 4-year institutional ethnography that happened between 2018 and 2022. Data was collected through participant observation at produce prescription programs in the state of West Virginia in the US, along with event ethnographies at planning meetings around these programs, wider conferences or summits about food access and health, and conferences and summits about federal policy that address these issues. I also did archival research, looking at how the policies and legislation that have come to govern these programs was made. So, looking through documentation from the US Department of Agriculture, different laws and acts, different hearings and report from the US Congress, and lots of other sort of marginalia that go with those things. So memos that people will have sent to each other's office about making these legislations, letters that have been sent in, expert testimony that's been used, etc. Alongside this, I also did key informant interviews with produce prescription organizers. So I did interviews across the US, but they're primarily focused on West Virginia because that was the case study was using. And I also did key informant interviews with federal policymakers. So people who were lobbying to get these laws passed, people who actually wrote the words that went into the legislation, as well as congressional staffer members, nonprofits, and academics who were involved in the policy creation process. So, in thinking about the proliferation of produce prescription programs, the way that policy has really championed them and then came to govern them. Dan and I thought about something, and then the implications for healthcare. Dan and I thought about something called the diffusion of innovations, right? And this framework helps us to examine the interplay of different factors to explain how information, programs, beliefs, and understandings spread, right? So, how ideas, practices, technology become adopted by not only individuals, but by systems and organizations like the federal government in the United States. So, the conceptual framework behind the diffusion of innovations allows us to look at this as a process, right? It's ongoing, it's constantly changing. So that process occurs between people in response to learning about new ideas. So produce prescription programs didn't appear overnight fully formed, but it was a very long process of changes in federal policymaking, in healthcare beliefs, in societal beliefs about the role of food and eating in health. Right? So there are different phases of diffusion. The begins with agenda setting and assessment, right? People seeing what's happening, what needs to happen, and then spreading that information, right? And then when we see what needs to happen, quite often there needs to be some sort of proof, whether it's proof desired by society or by the federal government, that this is what needs to happen and that's the solution in order for it to be implemented. So the literature on diffusion of innovations has talked about has talked how, the phases of diffusion, how it happens, but we need to explore the role of opinion leaders in the diffusion of ideas, right? How these ideas get taken up into policymaking, So this is where Dan and I saw an opportunity to combine our own separate work together to explore how opinion leading organizations and people like lobbyists, like nonprofits, like policymakers themselves have influenced food and nutrition policy. So this is a very brief timeline of the key points I found in shifts in federal nutrition policy that lead us to as an answer. And in my four key discursive shifts that changed policy over time. The first, on the left-hand side of that line in the red box, between the mid 60s to the early 70s, we saw a shift in the way that policymakers and society as a whole were talking about hunger and about redistributing surplus. So, a lot of nutrition policy in the US starts with the need to redistribute surplus crops that were that were grown because of government policies that benefited farmers who grew more. So instead of talking about redistributing surplus and addressing individual hunger, in the late 60s, we start to see a government focus on nutrition, right? And not talking about nutrition being, eating enough food, but nutrition specifically about making a healthy workforce. So in the 70s, in this green box, we have another shift where people start to connect health status to personal responsibility. This is in large part because of something what's called the Lalonde Report. So Mark Lalonde was a Canadian academic, a doctor. He writes a report called A New Perspective on the Health of Canadians, where he explicitly says health is singularly under an individual's control. And in all of the archival documents I went through, this report is actually specifically referenced many times in US policymaking, and is referenced specifically in the need to change policy, right? And the need to make people responsible for themselves. The 80s to the mid 90s, right there in that dark blue box. So this follows that connecting of health status to personal responsibility. But specifically in this time frame, they use that to justify austerity, the reduction of government spending, the cutting of benefits, or the tightening of eligibility. We also see the word or the concept of hunger being defined explicitly for the first time in government documents. This is under President Reagan's Task Force on Food Assistance. And they specifically define hunger again as an individual problem. They say that it's an individual issue that's not affected by society, politics, or economics. Then in the early 2000s to 2018, in that last gray box on the right-hand side, we see a shift towards what I've called precision welfare. So we're still focusing on nutrition. The individual is responsible. The government is trying to spend less money. But this is done through focusing on individual bodies, right? So funding for specific programming, such as produce prescriptions, is written into federal legislation, but the legislation is written in such a way that it focuses on individual bodies and even individual metabolic processes, which lead to a medical diagnosis. So, what this is doing is institutionalizing social norms we have around bodies, body size and shape, and body function. So, the 2014 Farm Bill, and the Farm Bill, in case you don't know, it's the premier legislation in the US that governs food, agriculture, and nutrition, along with other things like conservation. The 2014 Farm Bill really ties together these understandings of food and health because it introduced new funding to through the Food Insecurity Nutrition Incentive Program. So, if for incentivizing fruits and vegetable consumption, right? In the policymaking process, it was originally called the Hunger Free Community Incentive Grants, but this was changed because Congress wanted to shift the focus of incentivizing those who get benefits to access food, in increasing fruit and vegetable purchases and consumption. Right. So instead of focusing on fixing the problem of hunger, people are looking at individual behavior without necessarily looking at why those behaviors occur. This happens again in 2018 with the latest Farm Bill. Um, the Food Insecurity Nutrition Incentive Program was changed into the Gus Schumacher Nutrition Incentive Program. And this specifically includes a line of funding for produce prescriptions. So produce prescriptions were not written in to FINI, the Food Insecurity Nutrition Incentive Program, but a policymaker said that it was written in a way that those produce prescriptions would take off, become popular through being funded. And this did happen, right? So in the latest round of legislation, we see them for the first time named in the laws and the policies, specifically with earmarked funding. So the purpose of these federally funded programs is to demonstrate and evaluate the improvement of dietary health, to reduce individual and household food insecurity, and to reduce healthcare use and costs, which seems like a good idea, right? We want all of these things to happen. But again, only certain people are eligible for these programs. So either being diagnosed with or with the risk of developing certain diseases like hypertension and having a low income status. But you have to have both of those. So if you are low income and you're not able to eat food, but you don't have a diagnosed disease, you are not eligible for these programs. So, thinking about that conceptual framework of the diffusion of innovations, we see the uptake of really specific ideas, particularly through the work of opinion leading organizations. So, there are two very large um, nonprofit organizations that work on food access, particularly around produce, fruits, and vegetables. These are called Wholesome Wave and the Fair Food Network. And these two organizations were instrumental in getting a lot of the legislation passed from the early 2000s to today. So they had a hand in pushing for the changes in Congress for the way that these laws and policies were worded, and therefore how these programs are implemented. Right? And they come with very specific understandings of health, of good food and food access. Particularly, we see the spread of the food desert imaginary throughout US policy, where people only think about food access in one way. Not everyone gets their food from a grocery store, right? Some get them from corner stores. Some people grow food. Some people receive food from friends or neighbors or family members. And without considering these other ways of food procurement, policy really doesn't understand how people are accessing food. As I briefly mentioned, we've also seen the rise of these concepts of nutrition security and food as medicine, right? And food as medicine evokes a really specific understanding of what food is and what it's for. So we know as social scientists that food is nourishment for the body, but it also has cultural and emotional connotations and attachments, right? We have food rituals that are a part of our family units, that are a part of religious ceremonies or events, and cultures. But the food as medicine movement sees food as a specific intervention alongside pharmacology, right? And so what's happening is that it's moralizing certain foods over others without attending to socio-political structures that cause food inaccess or recognizing that food is more than just fuel. So the question becomes, right, where are these programs distributed? Who does the money go to? And quite a lot of projects that are funded by the federal government are affiliated with the two opinion leading organizations who pushed for this legislation to happen in the first place. And that is going to be the basis of some future work that I'm hoping to do. Right. And the way that the policy is built and implemented, the way that programs are implemented, even if they're not funded by the federal government, are really decontextualized from these broader issues that influence food access, right? So they're not considering the broader context of what affects individual and population health because they're adhering to certain logics and discourses, specifically really narrowly focusing on individuals and behavior, and reifying stereotypes and harmful assumptions about individual health. This has caused some tensions within program operations where some people want to be more focused on food justice and really just look at are people getting food that they need, while others really believe in food as medicine and want to collect as much biomedical data as possible to prove this concept, even though we all generally know that eating fruits and vegetables is good for us. So I saw this in West Virginia in the case studies I looked at, but it's not just happening there. This tension is happening in other programs throughout the US, and it's also happening in a lot of scholarship on health and food access, where we're seeing debates about people who are championing produce prescription programs with no reflection or critical analysis of them, and others who are reminding people that we need to look at these socio-political factors as well. Right. So we see a lot of parallels and diffusion in policy. So there's diffusion systems, administration, and expertise in federal government before the current situation, where the application of diffusion concepts by government agencies was pursued on a large scale in the 50s to the 70s. And we see this in the key shifts of federal food and nutrition policy from the mid 60s onwards. And thinking about policy diffusion, which is when new practices programs and policies spread through legislation, we see the codification, the legal definition of specific ideas people have around healthy bodies. And this really brings us into what people who study the sociology of health and illness call the weight-centered paradigm. So we're being trapped in this. And the weight-centered paradigm sees body weight as the center of discussions of health, where you are only healthy if you weigh a certain amount or look a certain way. And this really neglects those social, economic, and political determinants of health, which we know influence individual and population health. This creates a narrow focus in federal health and agriculture programs in the US, which is an issue because the relationship between weight and health is not actually as scientifically clear as many of us have been taught. And so there are a lot of questions about the recreation of inequalities within produce prescription programs and federal legislation, right? So this has a lot of implications for addressing health disparities, which we know have just gotten worse as time has gone on, right? So the recent White House Hunger Summit was found to fail to even think about the right to food, right? So people at the summit in the US didn't even talk necessarily about structural inequalities. And the inconsistent conceptualizations or understandings of health disparities and health equity mean that no forward progress has been made. And I always like to end my talks about this topic on advice from a fellow academic who looks at health equality issues. Her name is Marquiselle Mercedes. The first step to ask ourselves is, do we want to have people to have access to food, or do we want people to be thin? Right? And sometimes we have to really think about that. And after we've thought about that, we have to say, for those who help mobilize these initiatives, these programs, it's crucial to reconsider how we are evaluating the effectiveness of our work, right? Some biomedical data is useful, right? But that's not the only type of data we need to collect to see whether or not these programs are working, right? And as we consider how to evaluate the effectiveness of the programs, we need to reimagine the short and the long-term outcomes as steps towards food sovereignty, as steps towards people having the autonomy to make decisions about their own food procurement and food systems. Thank you very much. I really appreciate being asked to speak today and look forward to the discussion.
Right. Thank you so much for that lovely presentation. And we haven't really had any discussion on the US specific to particularly health and food. So, I'll just open the forum to questions. So, if you have any questions, you could unmute yourself and ask or put them in the chat box.
Hi, hi, Alanna. Thank you for the presentation. Can I speak?
Yeah.
Yeah, sure. Please go
Yes,
ahead. Yeah.
yes. Um, yeah, it's an interesting presentation that you were talking about moralization of food in the US. If you could have, elaborate a little bit on what kind of food they, moralize, that this food is medicine, this food is healthy, and don't, uh, they don't encourage other kind of food. That was a little bit that information would have helped us to understand, especially in comparison to India, because here moralization of food happens at certain other level, in terms of purity, impurity.
Mhm.
So here it's not about that you should eat healthy, rather you should eat pure food. It's more about ritual purity, because it's like you become what you eat kind of principle applies here. If you are eating beef, or you eating what they call non-veg products, so you are not eating the morally superior food. Yeah, sorry, I got diverted. So what if you can explain a little bit about what kind of food people consider there as, more desirable, good food or superior food in terms of health? So it will help us to appreciate your arguments better.
Yeah. So these programs are really pushing produce, right? Like fresh fruits and vegetables. Um, and they, and it depends on sort of which actors you're speaking to. But generally, there's the belief that people are eating crap. But when you ask people to explain that, sometimes they can't, or sometimes they all have different answers. So, for instance, one person thinks like cheese falls into the bad category, where another person would say like, we need dairy uptake in our lives, or there is cultural significance of dairy uptake. Um, so really what's happening is they're moralizing food in very broad terms where they're saying this is good, this is bad, but they're also not being specific about it, and they're
Mm.
moralizing behavior. So the eating of fruits and vegetables is now becoming a moral good. You're being a good citizen. You're being a good person because you're not going to be sick. You're not going to cost the government money. When we know that a person could only eat fruits and vegetables, but still get ill, right?
Yeah,
Um,
yeah.
and so there is this really murky, they don't have a definition, right? Where they'll just say, well, ultra processed foods are bad, but if you ask them to define that, they can't. Because like is a banana chip an ultra processed food? It's gone through a process. The banana's been cut, it's been like freeze dried or dehydrated, but it's still a fruit product. So what it is basically the bodies of poor people or people who don't look skinny are being moralized through perceived eating habits, but we also know that somebody else could also just eat fruits and vegetables and not be stick thin because they just have a bigger body. So I actually really appreciate the question because it's gonna help me write better. But it's also a problem of this whole process because they're not clear themselves. But
Yeah,
I
yeah,
think that
yeah.
also goes back to the fact, and I didn't talk about it in this talk, but the legislation also comes from trying to prop up failing farms in the US, where the US lawmakers want to be seen as helping the small scale farmer while also cutting costs of healthcare, while also cutting spending on benefits that people get. And so this program was thought of a way to solve these three issues. And in fact, they're called win-win-win because they win in each of these categories. And so to
Yeah,
prop up family farmers, they focus on fruits and vegetables, which are good, right? But like we also need whole grains in our diet. Um, and often they sometimes give vegetables that people don't know what to do with. So in the US, there's something called a patty pan squash. It's like a really tiny gourd. Um, and they're edible, but they were giving them to these communities in West Virginia who had never seen them before, and then were getting upset because people weren't eating them. But if you were given a vegetable like you've never seen, you weren't told how to prepare, of course you're not going to eat it. Right. But
Yeah,
then
yeah,
but then the medical practitioners were like, "Oh, people are so unhealthy. They don't want to eat vegetables." And I was like, they've never seen this before in their life.
yeah, 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 yes, yes, yeah. Yeah, if no one else is there, can I ask one more question? Like,
Sure, sure. Please go ahead.
yeah. So, what it appears is from your presentation that, like, typical of a modern society or European North American society, where you place the blame on the individuals. I mean, the responsibility on the individuals. I mean, that has been there since say, 60s to till date. Like, it's the individuals. In contrast to, again, in India, it is the community. If you are eating veg or vegetarian food or non-vegetarian, it's the problem with your community, the caste you belong to, rather than you as an individual. So yeah, so that's consistent with the way Western society emphasizes on the individuals to take responsibility for their well-being. But what I in that context, what I wanted to discuss is how capitalism, as you said, all these discourses are not talking about the structural issues, that why there is no access to food for certain kind of people. We don't want to discuss it. And maybe, I would say, if capitalism, the way the economies operate, so it doesn't give access to good food uh, to a large, I mean, to a section of population. um, but at the same time, um, you know uh, it's at the same time, it's also important to talk about the kind of food that is also available, in the sense, when we have these highly processed foods or low cost foods, or the way food is produced, for that matter, the capitalist mode of production of food, especially, I mean, whatever, all kinds of food full of pesticides, or very unhealthy process of producing food, which might make food accessible to people, but it may impact their health. In that sense, what is good food should also be a concern for us, rather than just having access to food. Because you can give access to food through, maybe, I don't know what, in the US they might have, suppose, for example, food coupons, etc. But what kind of food they're getting through those coupons? um, we should be also critical of the kind of food that is made available to the poor. And again, not blaming them individually, being responsible for not getting, not eating fruits or vegetables, but the what kind of food that are made available, especially the cheap foods that the poor people eat, in the ways is high fat or highly unhealthy food that they can only have access to. So here capitalism,
I'm
acts
sorry.
in. Sorry, I'll
Please.
finish it. Yeah. So
Yeah,
it
question.
acts as a double-edged sword in terms of not making available to the poor certain kind of food, but at the same time, what is made available, I mean, again through capitalist mode of production, is also at the same time unhealthy, isn't it? That's what. Um,
Yeah, well, it also depends on, again, on how often it's being eaten. Like, if I eat one packet of crisps, like, I'm not ending my life, right? Um, but there are also medical practitioners who argue like that fed is best. It's cheaper to go to McDonald's than it is to buy products and, make from scratch, especially when you consider, do you have the items like the pots, the pans, the knives? Do you have money for gas or electricity? Um, and so like if you're starving, it is better to eat from McDonald's than to
Yeah, yeah,
continue starving. Um, but but the issue is, like you said, that these larger processes, which are basically driven by capitalism, they're not being discussed, right? And so the problem is that policymakers in the US just blame the individual. They're saying this person is going to McDonald's because they don't know how to eat properly, because they don't know how to cook, instead of thinking, has their gas been shut off? Are they homeless? Are they, has the main income earner passed away and suddenly you're trying to feed your two children with a significantly less amount of money? So you're right that we have to think about what people are accessing, but the problem is that the the policy currently, it's not thinking that way, and it's placing a wholesale blame on folks, and again just pushing fruits and vegetables, which are good, but they don't make up the entirety of a diet for almost any group of people in the world.
yeah, yeah,
Thank
yeah.
you.
Thank
Thank
you.
you. Are there any other questions for Alanna? Okay, I have a question. I wanted to actually ask about the intersection of class, race, and health. Do you see any kind of ways in which, race and class come together to create this idea of moralization?
Yeah, I definitely do, because those intersections prop or they influence what people think of as healthy. And this was actually something that the PhD, I was not expecting it to go into this direction. I was just expecting to sort of like look at how, the policies themselves. But especially in the Anglo-Western world, the beliefs around health, are based on anti-Black racism and the sort of attempts to justify the spread of capitalism through colonialism and imperialism by placing the white body as the norm, right? So the BMI particularly is based on um, two populations in Scotland and France, right? And the entire world does not look like people in Scotland or France. Um, and it itself was not meant to be a measure of health, but has become such, where certain bodies are seen as healthy. And so if you don't look like that body, you're not healthy. And there is a scholar called Sabrina Strings who writes a lot about this, about how bodily norms were used to create our current understanding of health and norms in order to dehumanize sections, populations of the world who were being oppressed by, white people.
Okay, thank you. Thank you for that response. Any other questions? Okay, since there are no other questions, maybe we can wind up.
That sounds
So,
great.
yeah, thank you. Thank you so much for this very, very interesting talk. And the lecture is going to be uploaded on the official YouTube channel of ISS. So you can check it out once it's done, and I'll share the link with you. So thank you once again.
Thank you for having me. I appreciate it.
Bye. Bye. Thank you.